My name is Terry King. I am the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute, and the Vice Chair for Multidisciplinary Oncology. So the role of chemotherapy, whether given before surgery or given after surgery, is to reduce the risk of distant recurrence or metastatic spread. So we know that breast cancers, even though we treat them in the breast and the lymph nodes, we know that they can sometime return in other parts of the body 5 years, 10 years down the road from now. And really that's the role of chemotherapy, is to try to prevent that from happening. And chemotherapy works very well whether you give it before surgery or after surgery. So historically, we've given chemotherapy before surgery when women presented with very large tumors where the operation was going to be difficult. We were concerned that we wouldn't be able to remove all of the disease. So we gave chemotherapy before surgery in those scenarios to really shrink the tumors, make patients more operable, as we would say, and shrink the lymph nodes under the arm so we could do better surgery. We could clear all that residual disease. But that was in a time when we didn't understand much about the biology of breast cancer or the different breast cancer subtypes and which ones might respond better to chemotherapy than others. Fortunately, we have a very clear understanding of that now, and we separate breast cancers into different subtypes, and we know that those subtypes have different levels of responsiveness to chemotherapy. So for example, the triple negative breast cancer subtype, which is a breast cancer that does not use hormones to grow and does not express HER2, so we call it triple negative, we know that those tumors are quite responsive to chemotherapy. And so we think about using it before surgery to have a secondary advantage, again, to decrease the size of the tumor, which may allow a woman to have a lumpectomy instead of a mastectomy. And we also use it before surgery to try to clear any cells that may be in the lymph nodes to allow us to do less lymph node surgery. Again, by omitting the axillary lymph node dissection, which is the cause of lymphedema for a large number of women. So giving the proper chemotherapy before surgery can decrease the amount of surgery that we need to do. It also allows the oncologist to assess the response to treatment. So if you receive, let's say, treatment A for your triple negative breast cancer, and after treatment when you have surgery, if all the disease is gone, if the treatment has killed all of the disease, then you don't need any more treatment after surgery. But if you still have some residual disease in the breast or the lymph node area, then the oncologist will recommend additional treatment after surgery. So it allows us to, again, downstage disease and allows us to assess response, which helps the oncologist make subsequent treatment recommendations. So I mentioned it's very informative in the triple negative breast cancer subtype. It's also very common to give chemotherapy before surgery in what's called the HER2 positive breast cancer subtype. And in that situation, we're giving the chemotherapy with specifically directed anti-HER2 therapy. And again, these agents are quite effective, and we see very high rates of complete eradication of the cancer by using these treatments before surgery. We go to surgery, we're able to do smaller surgery, and then our oncologists again get that response by reading the pathology report. And if the disease is completely gone, then they would only recommend continuing on the anti-HER2 therapy in this particular case. Or if there is still cancer there, then again, they might change the treatment recommendations post-operatively. So it's really changed the way we think about treating breast cancer. It's not a one-size-fits-all approach. And we know, again, that some breast cancers will respond better than others. And the one group I haven't talked about yet is the hormone receptor positive breast cancer. So those that express the estrogen receptor and the progesterone receptor. We're moving away from using chemotherapy preoperatively in that breast cancer subtype, largely because we don't see the same levels of response. And so if we're not achieving response with chemotherapy in hormone receptor positive disease, then we really don't want to be using it before surgery to try to shrink tumors. It's not that effective. And we're now thinking about using preoperative endocrine therapy, or again, therapy directed right at the hormone receptor positive cells. We're thinking about using that more in the preoperative setting for patients with that particular subtype of breast cancer. So using treatment before surgery allows us to downstage the tumor, perhaps do a lumpectomy instead of a mastectomy, or a smaller lumpectomy, allows us to try to clear the cells from the lymph nodes to hopefully avoid lymph node surgery, and also allows us to assess response to treatment, which then helps the oncologist with their subsequent treatment recommendations. And we know that pre-op chemotherapy works better in some subtypes of breast cancer than others.